Morning, everyone. I do have a couple of slides because I'm not as talented as Dr. Gertz, so I can't just speak with a whiteboard. So I'll wait. As I wait for these to come up, I'll tell you what Greg asked me to do. He asked me to, I think the title. What does the title actually say? I think it's essential concepts for patients. So I called Greg on Thursday. I was like, man, that's a pretty broad topic. What do you want me to actually talk about? Can you go to the next slide? So Greg was like, with all the knowledge that you have, if you followed this talk, if you had just got diagnosed with myeloma and you heard Dr. Gertz's talk, what are the questions that you would recommend people should ask? So this is as if you just got diagnosed. So I have a philosophical first question. And then I have 3 questions that I think are important. So my first philosophical question is, what's with all the tests? So I think doctors love tests, right? I think everyone knows that. And when we don't have an answer, we just do a test. But myeloma doctors, I think more than everyone, all of doctors love to do tests. So I'm not going to go through all of these. So we have this big panel of tests when we first see patients. Can you go to the next slide? We're going to talk about some of those tests and why they're important. But I think as a physician, but also when you're going through this, I think as a patient, it's really important to know when a physician orders a test, what's it for, and how's it going to change what's going to happen? Because you're going to go through this for years and years, and there's going to be a lot of tests. And there are some physicians who will order tests and won't have a good reason behind why they're ordering them. So I have this list of just 4 things that you need to bear in mind as to why we're ordering tests. So the first thing is, are there any symptoms from myeloma? So you can present with these symptoms, as Dr. Gertz said at the beginning, but also as the disease returns, then there are symptoms that can recur. So are we measuring things like anemia and kidney failure? So this is number 1. Number 2, super important. I'll talk a little bit more about this again later on. How much myeloma is there? So we need to know how much there is at the beginning to know that treatments are working. And we also need to be vigilant if treatments do work, that things are not coming back. So there's certain tests that we do for that. What's my prognosis? We're going to talk a little bit about that. Super important question, I think. And then finally, what drugs can you get? So we put medicines in our body, they have to come out of our body somehow. And so we need to look at organ function, things like how well your liver's working, how well your kidney's working in order to give you medicine. So we do all of these tests and we're trying to answer these questions. We're often tempted to do other tests, but I encourage you really, whenever you have a test, really ask people, what are we doing this for and what's the outcome? What are we expecting? So this is just my philosophical first rant, but now 3 important questions. So I think I have about 15 minutes to answer these questions. 3 questions. What's my prognosis? How do we track the disease? We already talked a decent amount about that. And how do we make treatment decisions? So I'm going to, I think, give you philosophies rather than, hey, this is exactly how you should be treated, because everyone's obviously different. So let's talk first about prognosis. Next slide, please. So this is my only heavy data slide. And I put it up, I think, because a lot of you will ask this question about staging and prognosis. I also put it up because I want to illustrate a point about prognosis and myeloma and how we stage people. So just to talk quickly about some numbers, it's the only time I'll do this in the whole talk. We have a staging system on the left-hand side, which relies upon lab tests. A lab test called a beta-2 microglobulin and a lab test called albumin. So when your beta-2 microglobulin goes up, this is a sign of more myeloma. And when your albumin goes down, again, a sign of more myeloma. So we have a very simple test for myeloma doctors, two blood tests. So high beta-2, low albumin, higher stage, normal beta-2, normal albumin, lower stage, and then somewhere in the middle. And then to that, we added a couple of other tests. We added just a really simple non-specific test called an LDH. And then these genetic tests, which we do on the bone marrow. These are tests of chromosomes, tests of genetic material. And so everyone, whenever you get diagnosed with cancer, this is like a thing that you hear all the time. Hey, what's my stage? What am I supposed to do about my stage? And I bring this up because philosophically, I think this is really, really different in myeloma. So if you know someone with lung cancer or breast cancer, the staging is exceptionally important as to what we do as physicians. So stage 1 lung cancer, we cut that out, hopefully you're cured. Stage 4 lung cancer, the outlook's not as good, but the treatment changes a lot. I don't think it's the same in myeloma at all. We're just not that good at predicting how people do. And I think staging system maybe in this disease are almost because we felt left out. The other oncologists had a staging system and we didn't have one. So honestly, I tell people their stage. I think it's important information, it's important knowledge, but I think it's also important to understand that we might tell you, oh, you're stage 3, we're going to do more. It's not really based in a ton of data. So it's a very nuanced discussion about what we should do with this staging. There are other tests that we do for prognosis. So things like having bone marrow, having myeloma outside of the bone marrow, or even myeloma cells in your blood. We can say, oh yeah, that's really bad. We should probably treat that very differently. But truth be told, otherwise we don't have phenomenal data to say, well, in stage 3 disease, you've got to have more drugs. You absolutely have to go for longer, etc. So important to know these numbers, I think, but also important to know there's a lot of nuance. Actually, I think more so than in other cancers. Next, please. And you can skip through this. Okay, next. Okay, so how do we track the disease? Now, Dr. Gertz already talked about this. So bone marrows, horrendous test, super painful. Hopefully you get some medicines before you have a bone marrow test done, but it's not a viable way to follow the disease, right? Not only is it painful, but it's also not reliable, because if you move the needle a little bit, you get a very different number to if you went 1 inch in the other direction. So not a very good test to track how much myeloma we have for multiple reasons. We also have scans, and they're very fancy, but also expensive and a little bit of a hardship to go through. So this is the crux of how we track disease. So this is a super important number to know. As Dr. Scott said, this is a cancer of plasma cells. Plasma cells make normal immune globulin or normal antibodies. Your myeloma will make an antibody or a fragment of an antibody. The test to look for, the M protein test, is a serum protein electrophoresis. It will tell you how much is abnormal and how much is normal. So it will give you a measurement, oftentimes in a weight, 1 gram out of 1.2 grams. It's a really, really important number to track. That number is not always present on this test in everyone. And that's why we also measure these fragments, this kappa and lambda. And those numbers, if kappa and lambda is abnormal, those numbers are very important to track. So obviously a higher number, more myeloma, lower number, less myeloma. This test also has a lot of nuance. There are other things that can affect it. So it's not always the most reliable. I think all the physicians will tell you that this number, the number of times that you get referred people and you're like, this has been misinterpreted, or there are other things that affect it. For example, drugs, Darzalex will affect some of these numbers. Sometimes after a transplant, when you get normal immune recovery, these numbers can look abnormal. So it's really important, I think, to have experts looking at these. It's also, I think, very important to make sure that if you see an abnormality, something doesn't change straight away. You have to, oftentimes with these, sit tight and maybe check that again. I think another just super important point, I think, to say is that I'll oftentimes see folks who get this number checked very, very frequently. They say, well, I've been in remission 2 years and my doctor checks it every month. I'm not sure you need to do that. So normally we would say, we start a new therapy. After a couple of months, we should have this checked. And then if you're doing well, maybe every few months. This is a test that takes some time to change. So we can't react to say, oh, every week you've got to have it tested. Okay, so how am I doing time? Okay, so finally, how do we make treatment decisions? So we talked a lot about testing. I'm going to try and give you just a really high-level overview, because a lot of folks later on are going to talk about specific treatments. So how do we make these decisions? Here's the next slide. There's tons of drugs, right? There's just tons of drugs. And it's super confusing even for physicians who work in this area as to what the best treatment is. And again, it goes to the point of, hey, you don't need to always see your myeloma specialist, but I think you need to have contact with one when you're changing therapies or if you're changing doses. I think it's super important. So this gives you an illustration of how many drugs there are. And obviously on the right, steroids, Decadron, the classes are not important, right? So I just will tell you on the left, the backbone of the upfront treatment are drugs like Velcade, sometimes Kyprolis, Revlimid, and Darzalex. So I'm going to focus, I would focus on those drugs in the front line, but not everyone should get the same therapy. So I'll give you some kind of overview of what should go into the consideration of how we treat folks. So that's the next. Okay, so here's, I think, some of the philosophies behind how we make treatment decisions. So the goal is obviously we want to reduce the burden of disease as much as possible. We would love to get to 0. We can't always get there, and that doesn't mean that it failed. It doesn't mean that necessarily you should have more treatment added or treatment changed. But the goal, yes, is we want to reduce the disease as much as possible to avoid symptoms, to avoid breaking bones, etc. The backbone, like I said, are drugs like Decadron, plus something like Velcade, plus something like Revlimid, plus maybe something like Darzalex. These are probably the drugs that are used most commonly in the frontline setting. We favor nowadays using 3 or 4 of those, with Decadron always being one of them. And we know from fairly decent sized studies that using 3 or 4 is better than if we use 2. So if you're fit and healthy, we try to use 4 drugs as long as we can tolerate side effects. When we choose which drugs to use, and this goes across the entire treatment paradigm, whether we're talking at the beginning or later on in the disease, we try and also factor in not just the patient, but also, hey, what other drugs we got? What other side effects have there been? Other things like neuropathy that already exist that we want to avoid. And then I want to talk about something really, I think, that's very important that comes up a lot. We like to follow studies. We like to follow data. But not everyone in studies is the same as you. So it's really important to know that there may be very good reasons why you shouldn't receive a specific drug. Maybe it's side effects. There may be very important reasons. I think this is a very important point to make, that you don't get the same dose as someone else. We study these drugs in very relatively small cohorts of patients. We come up with, hey, this is the dose to go ahead in relatively small, I'm talking about 10, 15, sometimes 20 patients, then we apply it to everyone. So your dose of Revlimid might not be 25, it might not be appropriate because of certain side effects. So reducing the dose because there's a side effect or something's not right is totally appropriate for you. There's not, I think, a reason to push through side effects just to stay on a particular dose. Reducing the dose or reducing the interval of when you get certain drugs is very appropriate in many patients. Dr. Hagan's going to talk about transplant, so I'm not going to touch upon that. But everyone, the only thing I'm going to say is everyone should have some consideration of seeing someone who does transplantation, or at least having that question asked and answered. And finally, I think someone's going to talk about maintenance, but I think you shouldn't let someone sell you on the lie that if you have a transplant, you're not going to get any treatment afterwards. It's just not true. Everyone should get maintenance in 2022. And so expect that after a transplant, maybe there'll be less intensive therapy, but there should be some therapy afterwards. I want to switch gears. Sorry, I talked really quickly so I could get to this point because I think this is really important. I want to switch gears and be a little bit selfish and talk about something that I care about. But I also hope that I can make you care about it because it is in your self-interest as well. And so Greg asked me to talk a little bit about barriers to care and differences in access to care. And I want to do this in the setting that we want everyone to have fair access and everyone to get the same, just because it's not really fun to have this and we want everyone to do well, right? But also, I think it's really in all of our self-interest to include everyone. And I'll show you why. So I want to talk through a few of these points. So first, I think very importantly, I want to talk about race. So this is a disease that we know African-Americans, and actually people of African ancestry, I shouldn't say African-Americans, have a 2 to 3 times higher chance of getting. And that's not just in this country. If you go to West Africa, you find there's 2 to 3 times higher chance. So there's something genetic there. There's some reason why that happens. When you look, though, at how well people get treated in this country, and if you're African-American, you have a much lower chance of getting Velcade up front. You have a much lower chance of being considered for a transplant. You have a much lower chance even of getting this bone-directed therapies like bisphosphonates. So actually really, really unfair treatment. And so that's obviously morally bad, but also it makes a difference to us. So if you think back to, hey, 2 to 3 times more likely, there is a lot to learn there. There's a huge amount to learn that could affect all of us. There's a genetic risk. And if we understood that, then actually could really help everyone who has this disease. African-Americans also don't get into trials. They just don't get considered for trials for many, many reasons. That's a big, complex issue. But diversity in trials helps all of us. It helps all of us because we're really not all the same. So if you get a variety of people into studies, they're just better. They're better generalizable. We have more information and we can treat everyone better. So this is an important topic I think that we should all think about. I want to talk a little bit about location because there's data on this too. There's data on folks who live in rural populations who just don't get considered and sent to appropriate centers. So there's a huge difference in how folks 200, 300 miles south of here get treated compared to folks who are in the city. And that's a really important consideration for the same types of reasons. There's always stuff to learn. There's stuff about environmental exposures, to pesticides, etc., that could teach us about disease, that could teach us more about myeloma that we just don't know about because we don't see those patients. And finances, this is like, I think I shouldn't even be saying this is obvious, right? This has become a ridiculously expensive disease to treat in 2022, and this all gets passed on in some way to folks who are in front of doctors. So there's a huge disparity if you're not able to pay some of those costs that are passed on. And again, I don't even need to tell you guys that, but there's a huge amount of unfairness in passing on a few $1,000s to most patients. Okay, so that's everything I wanted to talk about.